So these are very difficult patients who have refractory heart failure. They come often in the hospital with hypotension, renal insufficiency, and persistent edema. So the first patient was a 66 years old patient with non-ischemic cardiomyopathy, was admitted for 2 days of worsening dyspnea orthopnea and paroxysmal nocturnal dyspnea. He's been on furosemide at home, metoprolol 25 twice a day, lisinopril. The admitted blood pressure was 94/78. Heart rate, he was tachycardic with clear evidence of fluid overload and right-sided heart failure, as evidenced by a jugular venous pressure of 12 centimeter mercury, 3/4 plus ankle edema. Patient is also cold and clammy. And is hypoxic, is tachypnic, the heart rate with a respiratory rate of 24. The initial renal function test shows that actually has got what we call prerenal azotemia, with a BN and creatinine ratio is close to 20, and really the patient is oliguric. He's only urinated 200 mLs in 8 hours, which is not adequate. What you expect from somebody who receives ADA via Lacey is about 1,500 mLs in 8 hours. Then, of course, the kidney function gets worse 12 hours later. Chest X-ray consistent with pulmonary edema, and on the echocardiogram, patient has clear severe left ventricular dysfunction, but has normal right ventricular dysfunction. In summary, this is a patient who has left-sided heart failure, known severe left ventricular systolic dysfunction, and now comes with progressive volume overload, develops renal insufficiency, and obviously it's relative hypotensive, okay? So I would like, first of all, to review with you his Swan-Ganz catheter numbers. Notice that after we admit the patient in CCU, the cardiac output is 3.2 liters per minute, which will cause an index about 1.6. So that's really cardiogenic shock level. Systemic vascular resistance over 3,000. Normal value is about 1,000. A PA pressure of 45/28. And notice that really, until proven otherwise, your diastolic PA pressure should equal the wedge. So even if you don't have that, unless you think the patient has interesting lung disease, the diastolic PA pressure actually it's an exo surrogate for that. And of course, wedge is 28. So the way I approach these patients, first ask myself, what is the volume status? This is a clinical assessment at bedside. You don't need any fancy test, okay? Number one, what is the volume status? Why? That will direct my management. If the patient is, I deem is euvolemic, that means I don't have to do anything about volume. If the patient is intravascular depleted, actually probably we should give fluids. And what kind of fluids and how, that's a different story. And the patient is volume overloaded, that means that if I really want to improve heart failure, one way or another I have to remove fluids. How and when, that's a different story. Now, we'll go over that. The second is, what is the perfusion status? Notice this patient we mentioned is cold. What it is, what I'd like for you to do is first to assess if the patient is warm, both central and peripheral. And I'm not going to have, actually, I'm going to go in detail over that, whether the patient is cold, both central and peripheral, or if it's combined, mixed. And I'll show you why that is important. Often the patient can be warm central, axillary region, and trunk, and could be peripheral cold. And then the third point is, what is the main clinical presentation of this patient with heart failure? Do we think that we're dealing only with left-sided heart failure? Do we think we're dealing with the right-sided heart failure? Again, clinical at bedside, or maybe it's a combination. And again, that will help us. And then the fourth point is really key in order for us to manage this patient. What is the renal function? And really, what I mean by renal function, I want you to be a nephrologist. I don't want you to be just checking a UA. You really need to know whether send the urinary and sodium FINA, a full UA, make sure we're not dealing with an infection. Ideally, if there's renal failure, if there is a prior sonogram, then use that. If there is no prior sonogram, do a full workup. Make sure the patient does not have obstructive uropathy, check at least a bladder scan. And this is very important. The reason is I cannot possibly remove fluid from the body in patient with heart failure if the kidney is not doing good. And I don't want to have any surprises from the kidney. There are things that we can fix before we start diuresing the patient. And then really remember that the best and fastest index of instantaneous renal function is actually the hourly urine output. I'm not saying we should, I'm not an advocate to put the Foley catheter in everybody. As a matter of fact, those who work with me, they know that I am strongly against of anybody of my patients who are on the floor of getting a Foley catheter. The reason is about a third of these patients by day 4 or 5 of hospitalization will get UTIs that cause major renal insufficiency in these patients with heart failure. So right before we are ready to discharge them, then we have to deal with something else. And also often that's a source also of confusion, both for the physician and for the patient. So that I'm not saying that. And I think we should put Foley only on those patients really on ICUs and breathing machine. I think that justifies the risk of causing the UTIs. And remember, if you do it on everybody, a third of them will get that. Of course, the patient has obstructive uropathy, different story. But really, I want both to record both the hourly urine output because that tells me the instantaneous renal function, where we're going. And in other words, it tells me the renal perfusion. And actually, probably is the best surrogate for a cardiac output. Because if your urinary output is good per hour, your cardiac output is good. You can't pee if you don't have a adequate cardiac output. All right? And then daily also, because you'll see there's a certain expectation. When we give a certain dose of diuretic, you expect a certain response. And that helps me to figure out how much I still need to do from one day to another. All right. So how to assess volume status? Because I propose to you that we should have a goal-oriented approach when we treat this patient. In other words, if somebody has acutely decompensated heart failure, has volume overload, okay, let's say has retained 20 pounds of fluid over their dry weight, okay? Remember that the way you accumulate fluid, first you expand your intravascular space. That elevates the cardiac filling pressures. Then the fluid will pour over in the interstitial space, all right? If I want to do the other way around, my goal being to normalize the cardiac filling pressures, that means I got to normalize first the volume status, intravascular volume. How can I normalize the intravascular volume if I don't normalize the interstitial volume first? Then it gets the intravascular volume. If I do that, I have to have a way of really estimating the interstitial volume. So the best way, so then I develop a simple rule of thumb. In my opinion, if somebody has 20 pounds fluid overload over their dry weight, until I get rid of those 20 pounds, I'm not going to affect the intracardiac filling pressures. The patient is not ready to go home, okay? And we should probably, during the hospitalization, target to remove about 80% of that extra volume. And like you would have a patient on dialysis, nephrologists, they know. How long do you dialyze the patient? Well, you got to remove whatever it is until you get them back to their dry weight. It's exactly the same thing. You have to be able to somehow at least semi-quantify the amount of volume the patient has retained. So here I come with a simple rule, okay, that applies for people here in this country, not in China. If you go in China, you have to cut this in half because they're a little smaller, okay? First of all, I would like for you to understand that the clinical presentations of patients with acute heart failure is very different from the clinical presentation of patients with chronic heart failure. So if you come suddenly in the hospital, acute pulmonary edema, flash, patient never had heart failure before, patients will have very limited ability to cope with all that extra volume. Immediate ongoing pulmonary edema will be clinically noisy. You're going to hear rails. You're going to see it on chest X-ray. You're going to have crackles, and a patient will be sick. Will be tachypnic. You're going to have pink frothy sputum. They may have some peripheral edema. Okay, that is not the case when patient has chronic heart failure. In other words, this heart failure has developed progressive. The volume accumulation was gradual. Okay, and it's amazing actually the sensitivity of actually rails on the physical exam, sensitivity of the pulmonary edema on the chest X-ray goes down close to 15%. So I'm always puzzled when I hear they call me from emergency room or one of you calls me in consult for heart failure. Well, this patient is well known with chronic heart failure. His weight is so-and-so. He's clear, short of breath, but I don't see any evidence of volume overload. He's got no rails. He's got just cardiomegaly on X-ray. And I think it's dry if there is anything. And I'm always puzzled when I hear that because you need to know that those signs are not present in patients with chronic heart failure. As a matter of fact, they can die in flash pulmonary edema with a wedge of 30, and you'll never see those signs, okay? And why is that? The reason is very simple. If you do it progressive, the pathophysiology is that progressive fluid accumulation in the lungs or in the interstitial space, in the belly, for example, will trigger and will allow time for compensating mechanisms to increase the lymphatic drainage up to tenfold, okay? And that will lead to actually absorption of the sodium and the water from the alveolar space into the interstitial space where you have enlarged lymphatics and veins. So suddenly the compliance and the capacity of the fluid accumulation in those organs can go up 5 to 10 times. They can accumulate 5 to 10 times more fluid that otherwise will do in acute setting. And the funny part about it, the doctors don't see it, so it suddenly becomes clinically silent. You're not going to see it on the chest X-ray. All you see a little cardiomegaly. If you're lucky, you see a little pleural effusion here and there, and you're not going to hear it on the physical exam. If you're lucky, you're going to feel some dullness, percuss, and see pleural effusions, okay? But for me, I see pleural effusion in those patients. That's a sign of volume overload. Take it. That's real, okay? So know that. You need to know that in chronic advanced heart failure, they really accumulate central the fluid, which means the trunk, means the lungs and the abdomen. Huge capacity, okay, before it goes in the legs. Even in normal, in acute heart failure, you still first accumulate here, then you accumulate in the legs. Only after the central part is exhausted, then it will go peripheral. But often, it doesn't have to be there. So often these patients may not even have peripheral edema. So you need to know that. Second, you will see indeed the objective JVP will be elevated. And really the objective findings I mentioned will be negative. No peripheral edema, no radius on lung exam, and negative chest X-ray, except maybe cardiomegaly and pleural effusion. Really, the most reliable way in this patient to detect volume overload is actually their symptoms, okay? And you have to act a specific way. For example, early satiety. How do you ask about? You have to know actually in initial phases of congestion of the stomach, actually what happens is they cannot eat the whole meal. They will eat less and less. And they will eat only half of the meal. Then between the meals, actually, they don't absorb enough food and nutrients, and actually they get initially paradoxical hungrier. So actually in early phases of fluid retention in the stomach or GI tract, you actually have a paradoxical increased appetite. If it has them, they'll say, oh no, I like a horse. Okay, my appetite is great, I just can't eat the whole thing. And they eat more frequent. That's the first phase. In more advanced phases, that's when they get really full. They can't eat anything, they start starving, and then their appetite goes away, and then they start to develop nausea, vomiting, and that's when usually the ER physician will do all kinds of workup that is negative for abdominal issues. All you see on the sonogram, liver sonogram, you see an enlarged liver with hepatophysiology, blood flow. So early satiety, ask them about if they can eat the whole meal. That's how you ask the question. Then you ask them about orthopnea, and you have to ask them in their own words. I've noticed this, that if many times the patients don't know about that. So if I was in New York, I had to ask them if they're gasping for air, okay? If you don't ask them, they don't get it. They say, my breathing is fine. I just have a feeling from time to time at night that I'm gasping for air, okay? And then if you're in South, though, usually they'll tell you they're drowning, okay? So everybody's a little different. Try to find as specific like that. And then really not the objective findings. So remember, not much of an objective findings in chronic heart failure, volume overload. Ask for symptoms, and that's enough, early satiety. As a matter of fact, I diurise them until the early satiety goes away, okay? How about objective actually findings for this? Because everybody can tell you anything they want. So objectively, this is how I classify the volume overload in this patient. I try to make it simple, and I'm looking vertical, okay? So if the patient has fluid only up on the pedal level, then I call that 1+. If it goes all the way to mid-ankle, that's 2+. If it goes all the way to below the knee, that's 3+. If it's above the knee, 4+. And if the patient's in ICU and you see thigh edema, remember in ICU you got to look in the back, okay? Then that's 4+ already. I don't care, okay? All right, and sacral edema. So then I multiply this plus by 5. That's 5 pounds, the rule of thumb, okay? So if you have that, you already have 20 pounds, okay? And if the patient has symptoms of early satiety, add another 5 pounds. If they have shortness of breath, in other words here, and they also have shortness of breath and orthopnea, then add another 5 pounds, okay? So then you add them up, and it's easy. You could have 4, 5, 6 plus times 5, 30 pounds. That tells you that before you can get these guys better so they can go home, you have long way until you remove at least that, 80% of that. Then they will get better. Then you can say that they will go home and stay home, okay? All right. Other markers, okay? A BNP level of 1,000. The internists are very shy to judge the BNP as a sole marker of heart failure, okay? But as a matter of fact, actually plenty of literature showing the BMP over 1,000, it's a poor marker for survival, even in those patients who have actually renal disease and they are on dialysis, okay? So even those guys that we think, oh, will cause false elevated BMP is still bad, the same way troponin is shown to be that. So really do not disregard BMP. As a matter of fact, BMP really is released by the stretch of the left ventricle. So all it means is that we're dealing with a chronic elevated LVDP issue, and you need to know that. So even the patient looks euvolemic, otherwise got a BMP of 1,000, always think, maybe did I optimize this patient? Do I need to go up on diurese? That kind of stuff. Of course, nothing is absolute by itself. Just think about that. Second, hyponatremia. Sodium less than 130, patient with chronic heart failure, bad news. That's it. So those guys, they will have renal failure. Those guys, you touch them with diuretics, they're going to get worse. Careful before you start to diurese them. Call me first. I'll teach you how to do it. Also know they are one step closer to the inotropes, okay? That is caused by inappropriate vasopressin secretion which is due to the neurohormone activation in advanced heart failure. Elevated right atrial pressure over 20 millimeters mercury. Bad news. By itself has a negative impact on the renal function. How do we know that? JVP up to the earlobe. Do not look for JVP here in patients with heart failure. Look here behind the earlobe because you'll miss it otherwise. There is nothing else pulsatile behind the earlobe but an internal jugular. If you see that, that's not carotid. Carotid stops here, okay? So look that, don't miss it. And if you see that it's equivalent on a right ear pressure over 20, that's equivalent on the echo. IVC is dilated, and it's not changing with respiration. Look on the echo report. That means the kidney, the renal veins, okay, and the splanchnic territory has no place where to drain their blood. So they're going to be congested. That by itself means bad news, okay? And that's why I put here, dilated inferior vena cava, systolic flow reversal, and hepatic veins on the echo. Okay, and the last, evidence of elevated left atrial pressure or elevated EDP. You don't need to be an echocardiographer, but at least I pointed out here things that you can take from the echo report that tells you that. So here's the deal. Of course, from the physical exam, you can hear an S3, which is under 20% unfortunate sensitivity in this patient. Presence of S3 requires two conditions. Number one, you have to have a big floppy heart. That means you have less than 20% and dilated. Number two, you have to have volume overload. It doesn't happen otherwise. I'm not talking about asymptomatic young guys. I'm talking about patients with heart failure, okay? So it is a sign of volume overload by itself. Rails, remember, sensitivity very low in chronic heart failure. Pulmonary edema, tachypnea, smothering, anxiety at night, and PND, all right? These are things that you got to ask the patient. And then from the echo report, it's when we say pseudo-normalized pattern, which will be equal stage 2 diastolic dysfunction and restrictive physiology, that's what it means. Really, the pressures are elevated. You got to diurese the patient. It's a sign of severe volume overload, okay? Restrictive physiology is more than advanced stage. I'm going to summarize now the pathophysiology of these circuits in patients who have predominant left-sided heart failure to begin with, right? Number one, the main problem, remember the definition of a patient with acute heart failure is elevated either left-sided pressures or right-sided pressures. So left-sided pressure, elevated LVDP, that's the main trigger, all right? The second will cause neurohormone activation for whatever reason. That's actually way before cardiac output is going to go down. That's very, very early stage, okay? Now these guys, the neurohormones, are the ones who are really causing all the insults, both on the kidney and also on the heart, okay? So these guys first at the kidney level will cause sodium and water retention with plasma volume expansion, volume overload, and guess what? It's going to make worse the LVDP, all right? Number two, it will also cause increased vascular resistance and renal vasoconstriction, which is present from the very first stages of heart failure, way before you have a drop in the cardiac output. Everybody equals heart failure with drop in cardiac output. That only applies to about maybe 10% of the patients. Most of the patients you see every day in the hospital for heart failure have this way before you have actually dropped cardiac output. Why is that important? Because inotropes does not help this patient. What it helps them, it's what's causing this, which is vasodilators, okay? And then, of course, if you keep pushing up and you increase the afterload of the heart by both increasing the plasma volume expansion and the elevated cardiac filling pressure and systemic vascular resistance and renal vasoconstriction, you're going to eventually drop the cardiac output, okay? And that's for the left side. And then last but not least, you keep having these cycles that are repeated. Usually when the kidney also gets back, eventually you back up and you have also right side heart failure. And we know once you develop elevation of pressures on the right side from the left side, that equals 50% mortality by 6 months. So we know it's also a bad prognosis, and that always coincides with actual development of prerenal azotemia. Therefore, in patients who have acute heart failure and develop acute renal insufficiency, the worse the heart failure and the worse the cardiac output, the higher the renal vascular resistance, as shown in this figure, which leads to inappropriate renal arterial vasoconstriction and overall renal blood flow reduction across the renal vascular bed. This strongly supports the notion that the mechanism underlying acute renal insufficiency in these patients is inappropriate renal arterial vasoconstriction. So this patient immediately, to begin with, I can prove it to you that's got left side heart failure as an initial etiology. It's got already right side heart failure and elevated right side pressures. It are in the third stage according to my classification, all right? And obvious, really the prerenal azotemia here is just a marker how advanced is the heart failure and how intense is the neurohormone activation, okay? Any questions about that? Pretty straightforward, good. And we come along and we're gonna start to give diuretics to this patient. They're cold, clammy, they have intense neurohormone activation. So what do you think diuretics are gonna do to this patient? Right? Look what I did. I put the arrows here. It actually, instead of actually, while the diuretic will make you urinate a little bit of sodium and lose some, actually triggers even more sustained sodium and water retention by itself. Actually causes more prerenal azotemia, and I'll show you that. And causes even more vascular resistance and renal vasoconstriction. So, and that because it really directly activates the neurohormones. And I'll show you, I'll show you the data for that. Anyway, so now, quickly, how about this patient? This patient is here. It's cold and wet. It's got probably low cardiac output too. It's got plenty of fluid on board, okay? And let's try to think about how we can manage this patient, okay? Well, here, we got an SVR of 3,000. We got a cardiac output of 3.2. Index is 1.6. And we got severe elevated LVEDP, 28. What shall we do first to improve this patient? Well, first, I think we should target the systemic vascular resistance. That's the first we should do, okay? If you were to just, and I went over the numbers last time with you, if we were to just give an inotrope now, okay? So imagine that the heart is a pump, and then you have the periphery is the faucet. Right before the arterial or vasoconstriction, actually the arterial vascular tone regulates the blood that will get into the main organ. So if SVR is 3 times higher than normal, it's telling me that the faucet is closed. Just because I increased the cardiac output and I made the pump stronger doesn't mean I'm going to have necessarily more peripheral perfusion. First, I need to open the faucet. Then, of course, if that's not working enough, you can also add an inotrope, and that together should improve the perfusion. That's what you like to do. I got to get the kidney better, otherwise I can't remove all that fluid. So it's very important, okay? And I promise you that if you were to drop this SVR from 3,000 to 1,000, which is normal, you will increase the cardiac output probably 100 or 200%. And I promise you that if you don't do this and you just give an inotrope, even the max dose, you're not going to improve the cardiac output more than 50%. So as a matter of fact, you can increase the cardiac output lots more by actually really normalizing the systemic vascular resistance first before you add that. Now, if that fails, you drop the SVR close to 1,000, then of course the next step makes sense. You should write the inotrope. Don't do it on all around. So that's what I'm trying. And it's really important because this patient has, what kind of vasodilator do you use and how do we do it? This patient has a blood pressure of, what did I say, it was 94/76 or something like that, okay? So you're at bedside, how do you know what to use? I always say whatever vasodilator you need to use has to achieve the goal of normalizing the systemic vascular resistance. And the systemic vascular resistance, the best surrogate at bedside is actually the mean arterial pressure. So I put here the formula for you so to refresh your memory. The systemic vascular resistance, it's a product of some kind of variable, a mean arterial pressure, and the cardiac output. And because cardiac output, a lot of it depends on the mean arterial pressure and systemic vascular resistance, you actually have twice more important mean arterial pressure in all this formula. So really, immediately I can tell you is that at bedside, probably the best surrogate for SVR in the absence of Swan-Ganz is your mean arterial pressure. And you could be as accurate as 80%. You almost don't need anything else, okay? So, and remember the mean arterial pressure really takes into account 1 time systolic pressure, 2 times diastolic. So if you were to just go by systolic blood pressure, you say, well, systolic blood pressure is 95, patient is hypotensive, I'm going to withhold the vasodilator. You're going to be wrong 2/3 of the time, okay? Because that patient needs vasodilators actually by vasodilating the periphery, increasing the cardiac output. Actually, you will increase the blood pressure, not decrease it. The reason why in advanced heart failure the blood pressure is decreased is not because you think, oh my God, the EF is 10%. No, and I will explain to you why. It's actually because the systemic vascular resistance is inappropriately elevated, and that drops the cardiac output. It's too much afterload for that poor heart. We have many patients who have an EF of 20% for many years. Most of the time, they're outpatient. I mean, they have perfect normal cardiac output. Otherwise, they will be, from the moment they drop their EF, they will be in the hospital for the rest of their life. Obvious, the cardiac output is adequate. Just because you have an EF 20% doesn't mean anything, right? What's missing here is only in certain moments their cardiac output becomes inadequate, and that's because something happened to the periphery and starts to increase the systemic vascular resistance, okay? So keep that in mind. So please, concentrate on mean arterial pressure. Think mean arterial pressure. Do not withhold vasodilators just because systolic blood pressure goes into a range of 90, which you're very unfamiliar and you don't like it. Go by the mean arterial pressure. And you'll see if you go by mean arterial pressure, this patient, even it looks like has a relative low blood pressure, actually has a mean arterial pressure of 83. So a really good mean arterial pressure for this patient is somewhere between 65 and 70. It should be higher than 65 because that's what the renal perfusion pressure needs. We know that the MAP is less than 65, the kidney is underperfused. If it's more than 70, then we know the periphery is too vasoconstricted. And that means it's fighting against the heart. So actually, you need to use a vasodilator. So you really want to use if it's higher than 70, use vasodilator. It's simple, okay? And you should use the vasodilator at the intensity and the dose that will drop the mean arterial pressure between 65 and 70. And if it's less than 65, of course, you can't use a vasodilator. So stop there, and I'll show you the algorithm. What shall we do with the beta blocker? Shall we stop it? If somebody's depends on how sick is the patient. The rule of thumb we have learned from clinical trials, we should never, if the patient's been on chronic beta blocker, the appropriate one for heart failure, we should not just stop it. Cut it in half or maybe a quarter if you don't feel comfortable. And then, because we know they get worse if they go in withdrawal from beta blockers with the remodeling. However, if like this patient has cardiogenic shock, needs ICU swan, sure, it's okay to start, stop it. Although, as I mentioned, you can cut it in two and then add you can still add an inotrope, but an inotrope, there will not be an anti-beta blocker. In other words, Renal, which will work below the receptors. Okay, so what medication should be used for this patient? When do you use a vasodilator? And which one? Nitro, nipride, nicertide, hydralazine. When should we use a pressor? Dopamine, norepinephrine, vasopressor. When shall we use inotropes? Like the butamine and Renal, okay? So the rule of thumb is this patient, we decide the SVR is high, we need to normalize that first. Obviously, we need to use a vasodilator. But SVR is 3,000. So what kind of vasodilator shall we do? Shall we use nitro? Shall we use nitroglycerin with hydralazine? Shall we use nitride? Or shall we use nicertide? And my rule of thumb is you got to use whatever it takes to get the mean arterial pressure where you need. So if it's only mean arterial pressure, it's only a little elevated SVR, you can use a mild vasodilator like hydralazine and nitro. And you can start with 10 IV of hydralazine. Ask the nurse 30 minutes later what is the peak of the effect to check the mean arterial pressure before and after, or a SWAN numbers. And then you see, well, it's more in the right direction, but I need more, then you add 20, and you do the same thing an hour later. And the 20 will do the job, then you keep on 20 Q6 or 24. If that doesn't do the job, switch to the intermediate dose of vasodilator, which will be nicertide. If that doesn't do the job, switch them on nipride. Bottom line is that these are not the patients that you'll see them in the morning, and then you see them back next day. You have to keep tailor it and go by goal-oriented until you get there. Simple. And start with whatever you're familiar with. Number one. Number two, remember, if you choose to do nitro, that's okay. But remember that 24 hours later, you're done with your nitro effect. If the patient needs more than a day tuning, nitro, you're going to develop nitrate tolerance. So that's, unfortunately, something that's not going to last. For acutely flash pulmonary edema, I think that's okay. But the next day, it's not going to work anymore, even if you use highest dose. Okay, pressors. Shall we use dopamine for this patient with low blood pressure? When shall we use dopamine? How about norepinephrine or vasopressin? Obvious. The way we know, we look at the systemic vascular resistance. If the systemic vascular resistance is below 1,000, it's low, that means the patient is too inappropriate vasodilator, then you can use a pressor, raise it back up. Don't do it more than 1,000. Just do it right enough to get it around 1,000. And then you're not going to hurt the heart failure. Okay, and I'll explain to you that. Now, if the systemic vascular resistance is higher than 1,500 or MAP is elevated, using a pressor will raise your blood pressure. There's no doubt about that. It will make you look pseudo-comfortable. But remember, the faucet is closed. You're going to aggravate, actually, the peripheral perfusion. So please do not use a pressor on those patients who are cold and clammy and poorly perfused, because even if the blood pressure gets better, it makes you look good on the paper, the patient is going to get worse after that. Okay? And then inotropes, as I mentioned, we use the Dopamine 5 mics per kilo per minute or Milrinone. Remember, no bolus. Milrinone, you start with 0.25 mics per kilo per minute. No bolus, you go up to 0.5. The heart failure guys prefer and love Milrinone. Okay? The reason is Milrinone is not only a great inotrope, which is probably similar potency as the Butamine. However, probably the Butamine is better, a stronger inotrope actually, but you'll have to use higher dose. But it's also a great vasodilator. It works by inhibiting phosphodiesterase and elevates the cycling AMP. Elevation of cycling AMP in the heart causes contraction, but in the arteries actually causes vasodilation. It's exactly opposite. So this is a wonderful. You get the best of both worlds. That's why the heart failure guys like it. And that works. Also works on causes pulmonary vasodilation too. So it's excellent for those patients who also have pulmonary hypertension, cor pulmonale, that kind of stuff. Okay, the Butamine, you have just beta-1 effect. Remember, you can't use it if you choose to still keep the patient on some kind of low-dose beta blocker. Okay, so this is how you pick one versus another. Okay. Now, so the way I would approach these patients, forget about the left side. Let's go over the right side here. These patients went in cold. I look at the mean arterial pressure. Okay, so first you assess the volume. It's wet. Then you assess the perfusion. It's cold. Then you look at mean arterial pressure. If it's more than 70, by default, the systemic vascular resistance is too high. The faucet is closed. You need to open the faucet. How do I open the faucet? Add vasodilator. Dose and frequency and type, depending, is goal-oriented, depending, what it takes to get the mean arterial pressure back between 65 and 70. Switch to IV diuretics. PO won't do anything. If this failed, if the kidney function got worse, patient is still cold. In general, if you consider adding inotrope in this patient, I advise you to send the patient to ICU. Cold cardiologist might need to do tuning, more fine tuning, depending on the swan. Okay, mean arterial pressure less than 65. Obvious, you cannot use the vasodilator because indeed this is where you can drop the blood pressure. Makes sense. Here, where I add the inotropes, either Milrinone or the Butamine, and I promise you, if your call is correct, ask the nurse to check the blood pressure 30 minutes later. I promise you, the blood pressure will go up right away. Okay, and you'll see it. And then after that blood pressure goes up, then you see the true systemic vascular resistance is also elevated. Then you need to back it up with a vasodilator because remember, the faucet is still closed. You also have issues with SVR. It's just that the blood pressure is too low. Okay, so in this particular patient, when I go through the algorithm, had severe volume overload with severe intravascular volume expansion. You don't want to give the patient fluid. We actually need to remove the fluid. So I'm going down the algorithm for this given patient. The patient was cold, actually very cold. MAP is 83. Need potent vasodilator to get mean arterial pressure between 65 and 70 to improve organ perfusion. Open the faucet. What is the clinical presentation here? Well, it's both left and right, but originally, I'm wrong, sorry. It should be here left side. Probably copy and paste from the other one. What is the renal function? The FeNA is less than 1% from renal vasoconstriction and possible low cardiac output. FeNA less than 1%, I'm always amazed by how nephrologists misinterpret this. A FeNA less than 1% can occur in those patients who are truly intravascular depleted and they are, they have low volume status and they are dry. I'm okay with that. Those are all over dire risk. But in a patient with heart failure who clearly has clinical evidence of volume overload, they're not truly intravascular depleted. As a matter of fact, they're intravascularly expanded. Remember, in heart failure, the only way you can get the fluid in the interstitium to see peripheral edema has to pass through the vascular space first. Okay? So if you see peripheral edema, you absolutely have to have intravascular volume expansion. If you have intravascular volume expansion, there's no way the kidney has too little volume going there. That's not the point. The reason why FeNO is less than 1% is actually because they're renal vasoconstricted. They have closed the faucet. And that is what we need to attack. It doesn't mean they are dry. Giving fluids is the worst you can do to these patients. So FeNO less than 1% does not equal fluid deficiency. Okay? It's only one little percent of all those causes. Okay? And I'll show you there are many others. All right? What is the underlying acute illness? I don't know. So now, before I start to manage this patient, I need to fix their kidney function. There's no way I can get the heart better until I remove the fluid. There's no way I can remove the fluid until I get the kidney better. So I wanted to show you a point here. Why is the patient developing worse renal function and has no significant diuretic response when you give 40 IV of Lasix? Okay? And that's because the patient has developed cardiorenal syndrome, which is now a mixed bag of things, which means pretty much in a simple way, development of renal injury in a patient who has decompensated heart failure. And this is the mechanism. Why the patient, as I mentioned, why the patient has prerenal azotemia. They have inappropriate renal vasoconstriction, okay, with actually plasma volume expansion, and that is consistent throughout all patients with heart failure, with acute heart failure. Some of them, on top of that, will also have renal hypoperfusion from the low cardiac output, but only few of them. But most of them will have this. So this is what we need to affect. How can we affect that? So what diuretic shall we use, what dose, and how to administer it, and how can we avoid further development of renal failure? To answer that simple question, which I'm sure all of you are very curious what goes through my mind, will require me 1 hour lecture, which I'm not going to do that now, okay? Suffice to say this. Number one, what we know is bad in diuretics in heart failure. Number one, a total diuretic dose of over 200 milligrams a day. So Lasix over 200 once you get to high dose. Okay. Number two, the bolus pulsatile administration. In other words, Lasix 80 QA is worse than if you were to give one dose or continuous administration. So we know that actually continuous IV furosemide protects. There is some evidence, and there's a clinical study that's performed now by NIH. We are not a site, but other hospitals are, where actually they compare the continuous IV administration of furosemide, the same dose total, should be 10 milligrams an hour for a total of 240 milligrams a day, versus giving the same agent as 80 QA. And so far, we have preliminary data showing that actually is the pulsatile and QA dose that actually makes it worse, is not the continuous. So if I were to give diuretic, I rather give once or I give continuous instead of writing this Q6 or Q8, whatever we've been taught that we should do. And I think that's probably not right, okay? And then the third, what really matters, and hopefully one day we'll have more evidence for that, is when you give it. You have to understand that these patients who have heart failure and they develop renal failure after you give the diuretic, they actually develop more neurohormone activation from your diuretic. So this is a study that was done at Cleveland Clinic where actually measure hemodynamics and neurohormones 10 to 20 minutes before and after furosemide. And look what happened. 40 IV of furosemide, which is a very tiny dose, okay? This is not 200, okay? This is 40. It's enough to increase the neurohormones by 50% within 20 minutes. And then that causes actually more elevated systemic vascular resistance, more vasoconstriction, lower cardiac output, and actually worse cardiac filling pressures. So in other words, if you were to just use the diuretic, loop diuretic by itself, that's the way it harms. Of course, the way it helps, if we remove fluid, we decongest the patient. But the way it harms is through activating neurohormones. And you're causing the same disease that the heart failure per se is causing. So my take-home message is that before I'm going to try to diurese this patient. Let's prepare. Let's first treat with vasodilator. Let's first normalize the neurohormones. Then if you were to come with diuretic, use a high dose, one hit, and then wait. And then you come back next day, and then reassess. See how it worked. Is the patient urine output improved? Is the renal function improved? And that kind of stuff. So please be aware of that. Now, if patient comes, this is only in chronic heart failure with chronic neurohormone activation. The diuretic causes paradoxical more neurohormone activation. In those patients who have acute flash pulmonary edema, they were prior warm, completely different story. Indeed, this is the classical teaching. This is where the classical teaching is correct. If me and you were somebody with flash pulmonary edema, who is prior warm, gets furosemide IV, it actually causes initial hypotension by causing venous dilation, decreased preload, and that's how they get better right away from it, okay? But that's mediated through a prostaglandin release in response to furosemide. Well, that does not exist in patients with chronic heart failure and prior neurohormone activation. As a matter of fact, they do exactly opposite. So keep that in mind, okay? All right, so this is what happens at the kidney level. This is the nephron. This is the lupum hale. This is the proximal tubule, distal tubule collecting duct. All this part, the top part of the nephron, it's in the at the interface between the medulla and the cortex, and very few of them are in the outer cortex. Now, the lupum hale is in the inner medulla. Remember that even normally, this is the most poorly perfused segment of the nephron. The purpose of that is to have the sodium, this is how we have the sodium multiplier current works. So we are able to retain about 25 to 30% of the water back in the body. That's normal. Now, you have heart failure. In the early stages of heart failure, you immediately, the most ischemic element, the first that will actually undergo hypoperfusion is this inner medulla, which is already poorly perfused. And then actually the blood flow initially, the total renal blood flow is actually most of the time is normal. That's why doctors keep disagreeing whether the renal perfusion is impaired or not actually in early stages. What is the total organ flow probably is okay, but there is redistribution from the inner medulla to the outer medulla and to the cortex. In more advanced stages, you also have ischemia eventually here too. In other words, the total organ perfusion goes down too. But initially, this is what happens. So what is the consequence if my blood flow shunts from the inner medulla to the top part, to the outer medulla or the cortex? Well, it's very simple. First of all, there will be less sodium reabsorption in the loop of Henle. If there is less sodium reabsorption in the loop of Henle, all that sodium moves all the way up in the distal tubule. And then immediately the distal tubule will see, oh, I'm having too much sodium that I'm going to remove. That means I'm going to lose water. So that actually triggers the tubulo-glomerular reflux that will release renin-angiotensin to try to preserve all that reabsorption. Somehow, actually, this is how the kidney figures that one way or another, the lupum Henle is not doing its job, okay? So then you reabsorb, so that there are two consequences of that. The renin-angiotensin activation, initially angiotensin to a low dose will cause renal vasoconstriction on the afferent arterioli and will raise actually the dam inside and maintain the GFR for a while. But then in higher dose will actually cause vasoconstriction of the afferent arterioli too. And then eventually when you have sympathetic activation, that causes really real vasoconstriction, okay? On the other hand, the activation of aldosterone will cause the distal and tubule and collecting duct to reabsorb sodium and water, which of course, together with the enhanced reabsorption of sodium water, the proximal tubule will cause more volume expansion. Now, if the sodium reabsorbs extra in the loop at the proximal tubule, how does it get reabsorbed with? What do you think it reabsorbs with? BUN. This is the reason why you have pre-renal azotemia and a BUN-F creatinine ratio about 20 in those patients with heart failure. For me, a higher BUN creatinine ratio, the worse is the renal vasoconstriction. It doesn't matter what leads to that, whether it's dehydration, whether it's left side heart failure, whether it's right side heart failure, whether it's sepsis. All it means that there is inappropriate renal vasoconstriction. So keep that in mind. All right, pay attention to that. Now, I think, and so we have this stuff here, all right, and that's how the renal panel looks like. Now I'm going to come, and I'm going to give loop diuretic. And then here, we have the ear physician will come with 40 IV of Lasix. What do you think the kidney is going to do when he's seeing 40 IV of furosemide? He's going to laugh at the ear physician. You know how the kidney laughs? it shuts down. You get worse renal failure and doesn't peak, all right? Because number one, 40 won't do anything. As a matter of fact, I can tell you how much of that 40 got into this patient because I expect from 40 IV of LASIK they should pee a liter, and he pee only 200. That means he got only 5 times less. That means 40 divided by 5 probably got only 8 milligrams that was seen in the interstitium, in the kidney, all right? Of course, that's, it's a simple rule of thumb. So first of all, if you were to use a loop diuretic, be aware that this part where your loop diuretic works is very ischemic. There is no blood supply. In other words, there's less kidney penetration. So if I were to use it, really you got to use much higher dose. That's why I'm not shy to use 200 and then knowing that only 40 will get there if I were to use it now. Number two, when you use the loop diuretic, this is going to cause us the same problem. It will cause more neurohormone activation, what I just showed you, and it will aggravate the same reabsorption and vasoconstrict mechanism and salt and water retention that I just showed you. The heart failure will do it. The difference is going to be much faster and much more effective. In other words, it's like the heart is going down, the kidney is going down from the top of the mountain, and my loop diuretic just gave the final push. No wonder most of these patients, if you were to just use the LASIKs, if they're cold and clammy, you're going to make it worse, no matter what, okay? So what we need to do is to prepare the field. Before I do this, I got to cut this neurohormone activation. I got to make sure I ensure the best hemodynamic status for that kidney. Then I need to use my loop diuretic to do the job. All right, okay. And remember, FeNAT less than 1% equals renal vasoconstriction. Does not equal intravascular depletion. That's wrong, okay? It's very 1% out of situation, very small. Now, if the patient is wet, there's no way the patient is dry. So forget about it. Now, if the patient is dry, the way you can figure that, just check orthostatics. If they're orthostatic, which they should always be if they're intravascular depleted, then that's easy. You stop it, give fluids, and you're set, okay? All right, so I talk about this. Start with vasodilators, and I talk about adding inotrope only the MAP is low, or it failed already. The patient still cold and claim worse renal function despite vasodilator. And I'm talking about evidence-based medicine. I want to show you there is a list of studies that was shown clear that if patient has heart failure and you give them, instead of going up, you give them diuretic or vasodilators. And instead of going up on, we can try to go up on the diuretic, see if it helps. In other words, you're below the threshold. Let's use more. Or go up on vasodilator, keeping the same dose of LASIKs. Well, it turns out that actually going up on the diuretic will only make them go faster on the breathing machine when you look at need for mechanical ventilation. However, if you actually go up on the vasodilator, you're more likely they're going to actually avoid acute respiratory distress and them going on the breathing machine. So there is some evidence for that. Okay, go up on that vasodilator. And then this particular patient was giving nitride, morphine, oxygen. Morphine is excellent for this patient to cut the catecholamine release, which is part of the cold and clammy type part. It's an excellent, if you want, anti-neurohormone and a vasodilator. Use that bang and kicks right away. And then after that, immediately, the blood pressure changed. You see the pulse pressure went up. Systolic is the same, but diastolic dropped a lot. And then the SVI went down. Cardiac output immediately increased from 3 to 4.6, at least 50%. Then patient, without any diuretic, pee 500 mLs in 2 hours, then 3 liters in 24 hours. After I fix this, now I can come back. I know the SVI is fixed. The kidney is getting vasodilated. It's having more blood, more perfusion. Then you can come with your whatever diuretic of choice you have, okay, and do it. And then, of course, next actually only require a day of nitride. We switch them to lisinopril and Coreg, and eventually diet is actually 10 liters in 3 days. So we continue with the vasodilator. And then really was sent home on day 4. Actually, euvolemia with normal BUN and creatinine. So the take-home message of these patients who come with left side heart failure and renal insufficiency and volume overload, first, fix the high resistance. Recognize it and fix it. Then you need to fix the volume because otherwise you cannot normalize the cardiac filling pressures. Then you come with your diuretics. And remember, before you use, you should rather use higher dose and just one shot, particularly if you don't know if you're hurting. Don't put the Q8 and Q6 because you come back next day, if you already did it wrong, you gave 2 more doses, so you activate twice more neurohormones. That's why you'll see me, I'm stopping that and I just give it once and then I wait. I come the next day and I reassess. See what the urine output was, perfusion, so long. and then use rarely inotropes only in those situations that fail the other part, okay? So I want to quickly maybe go over 2 more examples. This is a patient who has actually right side heart failure. 64 years old, sleep apnea, the standard. I have 3 right now in the ICU, 2 of them dying from it. Hypertension, now with acute decompensated heart failure. Recurrent mutations for heart failure, has over 40 pounds of fluid overload, cold and clammy, has severe TR, blood pressure 110/90, has right ventricular dysfunction with TA pressure of 70. However, the ejection fraction is normal. The left side is fine, 55%. Okay? Now the patient is cold and clammy. What do you think about if the patient is cold and clammy? What do you think about the cardiac output? So if the patient is cold, really, it means that you have probably at least, you have tissue hypoperfusion, and you have at least severe vasoconstriction. That may be associated with normal cardiac output or maybe with low, but chances are it will be low cardiac output too. And yet, how could that be possible in somebody who has right side heart failure, not left side heart failure? So, because it's not just all EF, it's inappropriate vasoconstriction, and what's happened with the RV function too. So, of course, the BN creatinine was 22/1.4, and now it increased to 66/2.2, pre-renal. And you see it gets more and more pre-renal. What does it mean? It gets more and more renal vasoconstriction. It is not intravascular depletion or third spacing. Why? Because I got anasarca. I got fluid in the interstitial space. To get there has to pass through the intravascular volume expansion phase. Okay? All right. So what happened? Well, urine output drops less than 500 mL over 24 hours. It gets the usual 80 IV of furosemide. Then the team recognizes the obvious that doesn't help. So they add the Dopamine to improve the right ventricular function, which I think is perfectly appropriate. They also try to improve the afterload and preload with IV hydrazine and IV nitro, okay? And that's okay too. Well, unfortunately, despite that, not much of a urine output, and the BN creatinine gets worse, okay? So in that phase, when it gets to that kind of dialysis level, of course, we call nephrology. And I can now tell you how many times there's no way you can ever get it right with them. So we call them for help, and guess what? They say, well, really, the kidney is fine. It's normal, okay? FeNA is less than 1%. You guys are wrong. Patient has perinosautemia, and has got intravascular depletion with third spaces. Give them some fluid. It will kick in right away. It works, and will open up those kidney pipes. And I said, okay, I guess that's a theory, all right? I'm okay with theories if they work. So we did what they asked us to do. We stopped the furosemide, continue with the support, hemodynamic and the Dopamine, and then give a bolus of normal saline over 10 hours. Follow up 24 hours later, urine output is worse, and the BN creatinine are worse. Now, obvious, whatever they thought is happening is not happening, and is not working as a therapeutic effect. So let me show you a little bit why is that not working, and it will never, ever work, okay? This is the heart of this kind of patients. The left ventricle is hyperdynamic. You don't need to be a cardiologist to recognize normally, this left ventricle is way bigger than the right ventricle. Here, you can see that the right ventricle, it's actually in this, what we call apical fortune, it's way bigger. This is the right ventricle. It's way bigger than left ventricle. It's squishing the left ventricle. The right atrium is huge. It's pushing the atrial septum into the left atrium. What it means is that when we look at the liver, this is the hepatic veins. Inferior vena cava, you see red flow. But it means the transducer is here. That means the blood is running away from the heart. It's got no place. All the veins, they're draining, whether it's SVC or IVC, they have no place where to drain in the right side of the heart. And that's because they're actually everything is too expanded. It's too much fluid in that intravascular space. It's above capacity. The pressures are too high. And, kidney also have not just arteries, but also veins. So in order for blood to flow across an organ, you have to have a pressure gradient across the organ. So actually, there's data showing that if the right atrial pressure gets over 20 millimeters mercury, immediately GFR drops by itself. That has nothing to do with the left side of cardiac output. It's a pure, renal vein hypertension issue, okay? So what you need to recognize now, we're back to the same issue where the kidneys, this time, will recognize the renal vein, there's renal vein hypertension. And there are studies showing that. And I'll be happy to share any of you. I just had to cut the slides because there are too many. But bottom line is that once you have renal vein hypertension, the right atrial pressure is over 20. Pressure gradient across kidney bed goes down to nothing. Immediately, the GFR goes down. As soon as the GFR goes down, we're back to ischemia of the loop of Henle. We are back to excessive sodium production at the distal tubule. We're back to enhancement of the glomerular reflux. And guess what? You get exactly to the same problem, but just for a different mechanism, okay? And they look exactly the same on their renal. They still look pre-renal, but they're not intravascular depleting or dry. They actually are really renal vasoconstricted because this activates the same renin-angiotensin mechanism as we know before, okay? And then we give the loop diuretic. Number one, won't get there. Number two, will enhance even more. No wonder when we gave her 80 IV of Lasix, just made it worse. And you tell me, well, what can we do then? I mean, what can we do? Well, what we need to do is to come up with a better plan to really fix this renal vasoconstriction. And what is it causing the renal vasoconstriction to begin with in the patient with right-side heart failure? Is the renal vein hypertension? Is the elevated right atrial pressure? I have to do something that drops the pressures on the right side. Number one, we need to remove the volume, and it doesn't matter what it takes. If kidney ions are on board and they are willing to do some dialysis, that's wonderful. If they don't do it, I'll be happy to do ultrafiltration, okay, to remove the fluid and give a kidney a break. And number three, we need to use agents that works on the right side to improve the preload and afterload of the right side. And ideally, some of those agents hopefully will improve the renal perfusion too. So some of those agents are, you can use nipra, you can use anything you want, but I use Neseritide because the data show that it works on the right side as well as on the left side. Now that's off the label. There's no evidence-based medicine, no double-blind randomized clinical trial, so this is full disclosure. I'm just saying these are sick patients that have not been tested, and one day we're going to show that. Anyway, so going through the patient, volume status, perfusion status is the same thing. You don't need to know any of those because at the end they activate the same mechanism. And basically the map was way too high. Again, 100 over 90. So we need to use a very potent vasodilator to be able to help this patient. The reason why the butamine didn't help because it's not a vasodilator. The reason why hydrazine and nitro didn't help because they were mild. I mean, you're using a baby dose to a giant. How do you think it's going to work? Okay? You need to use something stronger. And then this has both left and right side heart failure, but really mostly right to begin with is right side heart failure. And then you're going to tell me, well, why am I saying patient has right side heart failure but is having actually dyspnea or apnea, PND? It's actually having left side. LVEF is normal. Why? How is that possible? Well, I'll show you here how is that possible. The way you develop left side heart failure from the right side heart failure, you start first with elevated right atrial pressure. That's the first stage. That's what I call asymptomatic elevation of right-sided pressures. Second stage, that triggers neurohormone activation the same way the left side did it. Third stage, the kidney starts to act cuckoo and paradoxically start retaining salt and water and actually expands more the plasma volume and it elevates even more the pressures. Now you start to have clear peripheral interstitial edema. The second stage, what I call, is actually symptomatic right-sided, pure right-side heart failure. That's when patients start to have symptoms of right-side heart failure, such as early satiety, hepatomegaly, peripheral edema, that kind of stuff, okay? The third stage, now we keep repeating this neurohormonal circle. Now, once you activate also the norepinephrine, so initially it's mostly the kidney hormones. Eventually you get the norepinephrine hormones because fluid is so much. Now you're starting, the system is going to saturate. First, you fill the intravascular space, right side, peripheral edema. Then eventually it goes on the left side too, once you keep expanding. Remember, the veins have normally me and you, actually about 2/3 of all volume is actually on the venous system because veins have huge capacitance. They're elastic and all that. Then once you start to retain, expand that from 2/3 to 80%, but the whole volume goes up. Eventually, the venous system capacitance is overwhelmed and it will fill the arterial system too. That's when you start to also have elevated, together with the elevated vascular resistance, you also start to have elevated LVEDP, and that's when the patient actually develops symptoms of left side heart failure too. Pulmonary edema, orthopnea, PND, so long and so forth. And last but not least, they can get cold and clammy with evidence of low cardiac output too, even if the EF is normal, because the right ventricle is stressed out, the whole heart is stressed out, it's overstretched, in a bath of neurohormones that causes tremendous afterload. Okay? So whatever you start, you can start from the left, you can start from the right, you can get to either way by just simple activating more neurohormones and retaining more fluid. Okay? But either way, if you start with the right and you develop left, that's the third stage. That's bad news. Do not wait until the patient is symptomatic. They will go on the vent eventually from that. Okay? And the funny part, many of these patients with right-side heart failure, the underlying condition is the lung. I mean, if they have sleep apnea is one thing, but fluid with hypoventilation, if more fluid in the lung, they'll hypoventilate even more. The worst, respiratory mechanics. If you have COPD, fluid in the lung, it's not good either. So long as of interstitial, pneumonitis or lung disease, again, they suffer. They will feel sick. So volume becomes part of the disease here. So once again, when you develop the third stage of left-side heart failure in these patients, they also coincidentally have peripheral azotemia. And we come with the diuretics and we make it worse. Okay, it's very simple. All right, and so this particular patient, actually, I switched her to Mirinol, which again is more complete inotrope, not just left, but also has vasodilation, particularly pulmonary vasodilation type effects. So if I were to use an inotrope, use one that also works on the pulmonary hypertension to reduce the afterload of the right side. Also, actually use initially hydrogen and nitrate, but eventually actually switched to Neseritide, which is more potent than that. And then we added actually what I call double whammy, the higher dose of loop diuretic with, you need to recognize there's diuretic resistance because you have all that reabsorption of the distal tubule. So first use your diureal to knock that down. Then you use your loop diuretic. So if I were to use, I do that. And I give one dose and then I wait. And believe it or not, this patient actually pee suddenly from 500 cc's, 5 liters a day for 5 days. We got 25 liters out. And believe it or not, if you do it the proper way, actually the kidney improves because you're cutting the neurohormones and then was weaned off vasodilator and changed to PO. And was sent home with the BN and cranials close to baseline. Of course, that doesn't mean I cured this patient. You got to treat the underlying disease, sleep apnea, or pulmonary, whatever is causing it, pulmonary embolism. So, it may still be bad, news for this patient too late. But at least if I were to have a rational approach, that's how I do it. Okay? So we are done with this last part of the algorithm. And then I wanted to show you a weird entity that occurs every day in what you do in these patients. And we fail to recognize, and that's how we fail to help the patient, okay? And the last one that I'm talking about is patient who has left side heart failure, but also develops hypotension and something else that actually works against us. So this is a patient who has a similar clinical scenario. This time the blood pressure is 88/40. Has sinus tachycardia, has 3+ ankle edema, obvious, has volume overload, and has a little orthopnea, and is not cold and clammy. In contrast, it's just warm. Now, it doesn't have fever either, but it's warm. It's tachypnic, has a clear perirenal azotemia picture, a BNP level of 1200, the chest X-ray, just mildly enlarged heart, as I mentioned, no interstitial pulmonary edema. In other words, no evidence of fluid overload in the lung. EF is 25% and has normal right ventricular function. So what do I think about this patient? Here is how I think. I think this patient has left side heart failure, has clear volume overload. So what if I don't see it on the chest X-ray? I know that from my peripheral edema. Remember, you can't get peripheral until you accumulate first central. Then it gets peripheral. So actually, before you accumulate something in the legs, you already have 7-10 pounds in your lungs and in your stomach. All right? Just because X-ray doesn't show it doesn't mean anything. Number one. Number two, I know there's something else that tells me that's correct because the BNP level is 1200. Remember, you cannot get to 1,000 of BNP level when it doesn't matter what's the creatinine unless you stretch the heart. Okay? And then last but not least was really striking. This patient is really hypotensive. Now, if I were to go by systolic, that's low, but I'm not happy enough. I'm looking at diastolic, 40. I mean, if you're heart failure, I bet you, I promise you, in pulmonary edema, your diastolic will be higher than 70. This is 40. That means that the mean arterial pressure is less than 65. That means the SVI, it's under 800. This patient is septic or has what I call SIRS, systemically inflammatory response syndrome. Inappropriate vasodilation for whatever reason. Their intravascular volume, instead of being 5 liters, goes up to 8 liters. So you open, suddenly the faucet is completely open and you have a lake instead of having just little rivulets, okay? So because of that, that means the blood is going the wrong way. is not going in the main central organs like the kidneys and the brain. It's going to a skeletal muscle, but the patient is not running. What do you need to go your blood into the skin, in the skeletal muscle if that's not working? So it's stealing away actually blood from the kidney. That's why you get renal failure. So I asked the house staff, I said, well, this patient is septic, but there is no fever, there is no white count. Why are you out of your mind? You know, and I said, well, the way I think in these patients who have very poor, low cardiac, low heart reserve, remember to build fever and to build neutrophils or leukocytosis. You actually need blood support from your bone marrow. You need blood supply to your skeletal muscle to get a fever. So think that you can have a masked clinical presentation in these patients. They need, I always think bad heart failure equals bad, end-stage AIDS, CD40, and it can be masked. And indeed, we had to swan this patient, and we proved that despite all this bad news with the low blood pressure and the low EF, patient had a cardiac output of 6 with an SVR of 650 that confirmed that it's actually more septic than, or has some kind of systemic inflammatory response syndrome as opposed to that. Notice that the wedge is 24, which is not so high for somebody with heart failure, and a CVP of 18. Pay attention to that because I'm going to ask you a question. Okay, what shall we do first? Shall we give fluids? Shall we give inotropes? Shall we give pressors? Shall we give vasodilators? And last but not least, shall we consult renal? Because look at the BUN and creatinine. This is dangerous level. All right. So who wants to give fluids? Good. Who wants to give inotropes? Good. Who wants to give pressors? 1, 2. Okay. I guess so far we don't have many therapeutic actions. Most of you guys don't want to give anything. What is the volume status? So we know if we need to give fluids or we need to take away fluids. So what's the volume status of this patient? High. Obvious. And I have the gold standard. I have the wedge. It's more than 18. That confirms. I don't care what the chest X-ray shows. I don't care what my clinical assessment of volume status is. The wedge is over 18. The patient's volume overloaded. Period. Do not give fluids unless you want also the patient to be short of breath on top of that. Okay? The heart is overstretched. You're going to stress out the heart if you do that. Number 2. All right. So we clear that out. No fluids. If there's anything, we might need to remove, but I can't do it now with no kidney. So I'm not saying we should give diuretics now. Number 2, what's the perfusion status? Now I'm trying to figure, do I need to use pressors? Do I need to use the vasodilators? Do I need to use inotropes? That's how I'm figuring. So the patient is warm both central and peripheral. And the MAP is less than 65. Patient is severely vasodilator. We cannot use vasodilator. You kill the patient. Give 1/3 dose of nitro. These are the patients who will never come back with their blood pressure after that. Why? Because the mechanism of sepsis induced vasodilations through release from the periphery of nitric oxide, okay? And so, the patient is already in a bath of nitroglycerin, endogenous nitroglycerin. You give that, you're going to make it worse, okay? So what we need to do is actually the other way around. You need to use pressor to close off the dam so you shift the blood back into the central circulation. So the kidneys start to perfuse, okay? So actually put the patient in the ICU. Use a pressor at the low dose or whatever it takes to get back MAP to more than 65 or the SVR if patient swan. And if you're in doubt, swan the patient. These are the patients who will do better to help you out. Okay, what's the main clinical presentation heart failure? Is left and right, but really left is the original one because the RV function is okay. And then renal function we said is FINA. And why is that? I think it's because of combined heart failure and sepsis. I removed those 3 slides that showed that actually the sepsis can cause renal vasoconstriction. But I'll show you. And then the underlying acute illness. Well, this is an elderly from nursing home. If the patient is supposed to have sepsis, what do you think is most likely source? UTI, right? So it doesn't take a lot of detective workup for that. So really, here, the reason why I show these patients to also make a point, there is not just right side or left side heart failure that will cause you renal azotemia, but also sepsis can cause renal azotemia. And it's sepsis actually through the same mechanism, sepsis-induced renal vasoconstriction. It is not, once again, intravascular depletion. We know this patient is not intravascular depleted because the wedge is 18. Left-sided pressures are elevated. Heart is stretched. Heart and vessels are one system. You can't have fluid in the heart and no fluid in the vessels, okay? All right. So that's the mechanism. And if you want to, this is actually documented by a nephrologist. This is not something that I say. What do I know about the kidney, okay? I'll be happy to share this review paper with this guy who's, an expert leader in the field. What he says is that putting everything together, really, if you have any kind of SIRS-like mechanism, whether it's severe gout attack, systemic gout attack, lupus, what is infectious etiology, like E. coli with endotoxin, that causes peripheral vasodilation. And that immediately, once you have peripheral vasodilation that drops the mean arterial pressure below 65, activates the baroreceptor to activate the sympathetic system, which will try to cause vasoconstriction. But the periphery, the effect of sympathetic system periphery will be blocked because you have a bath of nitric oxide. But the sympathetic system in the kidney, actually will cause renal vasoconstriction. So that's an indirect way. Also, another way of actually how this happens is actually the cytokines that are released with all these, a common denominator for all these SIRS-like, systemic SIRS-like illnesses. They all release TNF-alpha, IL-6, IL-1, and guess what? They do peripheral vasodilation and then actually kidney vasoconstriction. So TNF-alpha is one of those mechanisms that no matter what kind of animal model of renal failure you cause, it mediates that, whether it's toxic effect, diabetes, anything else. So those cytokines indirectly, you don't have to have a pyelonephritis to develop renal failure from an UTI. You can have UTI, which releases cytokines. Then you have heart failure, which also releases cytokines. Then 1 + 1 suddenly equals more than 2. And that together causes actually the renal failure. It's the cumulative effect of all that, okay? And I removed those slides. What the take-home message is here, that any kind of worm-like illness in this patient with heart failure actually will cause peripheral vasodilation, but paradoxically, actually, renal vasoconstriction. So that's the reason for perinosautemia. So what we need to do is imagine this patient has left and right side heart failure and pressures and all that, messes up the kidney, and you got perinosautemia the way I show you, and then I have the sepsis, and then I have the diarrhea. So of course, patient, if you give direct diarrhea, you're going to mess it up, and then sepsis will do exactly the same thing, okay, once again. And so how do you approach these patients? Well, first, do not harm. So don't give fluids because patient has heart failure. His pressures are too high and heart is too stretched. Well, but avoid vasodilators too. Obvious, this patient is too vasodilator. So do not use ACE inhibitors and ARB in these patients because they need that low level of angiotensin activation in the kidney to maintain the kidney perfusion. And remember, at the low level is good. It's not everything wrong. It's the low level. And if you use a dose, you never know whether you just take the edge off or you block it completely. As a matter of fact, the rule of thumb, and this is in the HA guidelines for heart failure, do not hold, please, the ACE inhibitor or the ARB if the patient has perinosautemia. For whatever reason, it doesn't matter. And this is the reason that I showed you, renal vasoconstriction. That's when we're supposed to hold it. And then wait until that resolves, then you start back as outpatient. Remember the benefits, ACE inhibitor, ARB, long-term, stable renal function, mostly creatinine, not the perinosautemia type state, okay? And then avoid the vasodilators. Postpone the diuretic use unless patient is really sick and pulmonary edema about to go on the vent. Sometimes I'd rather let them go on the vent because I preserve the kidney, then I fix the kidney, I can get them off the vent. But if one diuretic can actually kill this patient, their kidneys, okay? Be careful. So postpone it. Don't resist the temptation to do it. Then do whatever you do. Get the patient the unit, get the mean arterial pressure above 65, which is above the minimum required for adequate renal perfusion. That's what we need to do. And the sooner the better. Even 2 hours of MAB less than 65 predicts a creatinine of 4 next day. Okay? So if you cover at night, a resident, you have a confirmed MAB being too low, less than 65 for several hours, move the patient to the unit. Don't wait for 3 or 4 hours when creatinine is already 4 next day. Okay? Hypotension by itself, we know, causes renal hyperperfusion, sepsis. And then treat the underlying. Don't wait for the patient to develop fever or leukocytosis. Please, just be a little detective. Send all the workup, cover with antibiotics. Then 2 days later, patient's fine. You didn't find anything. Shut down the antibiotics, no problem. But first you treat, then you think about it. Okay, and then look for gout, knee, whatever SIRS. So this patient, you don't give fluids because according to the septic shock algorithm, first you resuscitate the fluids, right, until you get a CVP up to 12 or a wedge at 14. This patient is 18. This patient is already fluid resuscitated. Actually, if you give more, you're going to make it worse. Number two, if you go down the septic shock algorithm, the MAP is less than 65, then you already resuscitated the fluid, then you should go down and resuscitate with pressors. My favorite choice of pressor is not dopamine, okay? is actually norepinephrine. It's at low dose does only vasoconstriction. At higher dose may give you a little bit of beta effect too, in case you have some inotrope effect. If you use dopamine, you never know where you are, whether you're at the low dose vasodilated at the alpha blockade or beta, and even 20 mics of dopamine is actually ineffective compared to 10 mics of Levophed. 10 mics of Levophed is way stronger than 20 mics of dopamine. Okay, so I gotta go straight from the main guy. Let me do the job. Okay, and then if I'm at 10 mics of Levophed, 20, and those are not working, then I'm in trouble. I gotta switch to a different one. Add the second pressor, like vasopressin, like it happened for this patient, because 20 mics of Levophed didn't do it. It didn't raise the MAP. Many of these patients will be catecholamine resistant, particularly if they have endotoxin or lactic acidosis. Remember, always check lactic acid level on these patients. The lactic acidosis, or in general the acidosis, is the single most potent vasodilator on earth. They will be catecholamine resistant. You'll see if they have respiratory acidosis. It doesn't matter what's respiratory, whether it's in patients with COPD and sleep apnea, or whether it's metabolic acidosis. You will see those patients who always get severe peripheral vasodilation that is resistant to catecholamines and renal vasoconstriction. Hypercapnia and metabolic acidosis directly causes renal vasoconstriction. So then actually catecholamines won't do the job. You have to use an agent that will help you resensitize back to catecholamines. That's vasopressin. That's why once I'm above 10 of Levophed, didn't do the job, immediately I add my second choice, vasopressin. And then I tell them to titrate down the Levophed to keep the MAP between 65 and 70. Okay, and that doesn't work. And remember, these are not antibiotics. I mean, you can do all this stuff. You keep scratching your head whether you should give antibiotics because the patient doesn't have fever and leukocytosis. You figure that next day, the patient is gone, okay? At least their kidney, they go slower. Anyway, so now you say, well, is there any role for dobutamine here? Come on, you resuscitate this. Sure, cardiac output is 6, but how do you know for that severity of septic shock, it may not be to be 8? How do you know? EF is still low. So the way I do it, you can still do it in goal-oriented approach, and we know that in algorithm. I check all that. If the mixed venous is still less than, it's not 70%, it's less than 60%, obvious, maybe I have also inotrope deficiency. So you add dobutamine on that too, to make sure. If you're in doubt, you don't have a mixed venous, add it just in case, but make sure that you know that the pressors really are doing the job, okay? All right? Any questions? Clear? All right. So that's what we did, and patient metastatic urine output improved. I didn't diuresis at all. All I need to fix the perfusion of the kidney. And then nicely, patient pee on her own. And then urine cultures came back 2 days later for over 100,000 E. coli. And then eventually improved, was discharged 7 days later with normal BN and credit on low dose lisinopril. Okay? So let's go summarize this with the algorithm. Okay? Number one, patient is wet and warm, like this patient. MAP is less than 65, confirm. 3 different measurements, and you know that's a real number. Don't wait. Actually, they feel great, by the way, in early stages. They'll talk to you because they got too much cardiac output going everywhere. That's why they look so great. It's what I call silence before the death of the kidneys, okay? So, they're warm. Don't wait for too long. Get them in the unit after 2 or 3 hours. It doesn't work. Of course, if you're in doubt, give them your fluid bolus. If they're volume overload, don't give fluid bolus. Just move them in the unit and put them on pressors. And then start to think search, sepsis, whatever. Vasopressin, Levophed, inotropes, go down the algorithm the way we talk. Patient is wet and cold, all right, too much volume and too cold. The faucet is closed. Open the faucet, MAP more than 70, you can do it on the floor. Open the faucet by using vasodilators, switch to IV diuretics, and if that doesn't work, add inotropes. Involve the cardiologist to help you with that when you get to that stage. Wet and cold, MAP less than 65, inotropes to begin with, because you cannot use a vasodilator. Then use a vasodilator to get if the MAP is more than 60. And then really, this is a list of those patients we know they're sicker than what you think with heart failure. And we know the standard cardiorenal syndrome with prerenal azotemia, low EF, severe concomitant RV dysfunction, severe valvular disease, bad AI, bad MR, refractory heart failure, severe volume overload. So to summarize, what are our goals of management in the patient with acute decompensated heart failure? Number one, we'd like to lower pulmonary capillary wedge pressure or right-sided pressures, and the best way to achieve that is to use actual goal-directed vasodilators. Really, idea we like to achieve the goal of mean arterial pressure, lower it between 65 and 70 millimeters mercury, which would correspond roughly to a systemic vascular resistance about 1,000. The second, we know we cannot normalize pulmonary capillary wedge pressure without actually normalize the volume status. To achieve that, we have to have a goal-directed removal. Ideally, we like to estimate and remove about 80% of total amount of volume overload that is above the right normal weight for a given patient, either using a combination of diuretics or ultrafiltration, such as in refractory heart failure. The third, we like to avoid, by all means, the development of renal insufficiency. One way of doing that is to avoid the neurohormone activation that causes renal vasoconstriction by pre-medicating with vasodilators before we actually use diuretics, particularly if mean arterial pressure is more than 70 millimeters mercury. Also, we can pre-medicate with inotropes if the patient has been on vasodilators and patient is still cold with worse renal failure, or if the mean arterial pressure is less than 65 millimeters mercury. In contrast, we like to avoid vasodilators if the patient is warm and has a mean arterial pressure less than 65 millimeters mercury. That will suggest a underlying systemic inflammatory response syndrome, such as gout attack, UTI, or any other conditions. And last but not least, we like to avoid a frequent use of diuretic 3 times a day or 4 times a day. It's better to use it only once a day, or better, continuous intravenous infusion at 10 milligrams per hour.